Good afternoon. Please come on, if you're grabbing a seat, come on up front. There's lots of room up front. We will have people, no doubt, drifting in after lunch. Good afternoon. I hope you enjoyed a great lunch and spent some time with the fantastic poster session. I'm Dr. Kevin Roy, Associate Professor in the Department of Family Science in the School of Public Health here at College Park. And I'd like to welcome you to the first ever panel on violence prevention at Public Health Research at Maryland Day. I'm co-moderator of this panel along with Susan Esserman, and we have three fantastic panelists. So in terms of the agenda, I'll have some opening remarks and then introduce the three panelists. They'll each spend a few minutes to discuss their research on violence, prevention, and health. And then Susan Esserman will also have a moment to speak. And we'll have a prepared question for all the panelists to begin the discussion, and then we'll open it up the mics for questions from the audience. Violence is now clearly recognized as a public health problem, but just 30 or 40 years ago, the words violence and health were rarely used in the same sentence. In 1979, the Healthy People Report from the Surgeon General first identified violence as one of the 15 priority areas for the nation. And in 1983, the CDC established the Violence Epidemiology Branch to focus its public health efforts in violence prevention. In 1993, the first special issue of Health Affairs addressed violence as a public health issue, and the CDC established the Division of Violence Prevention. What contributes to the growing reception and acceptance of violence as a public health concern? As we become more successful in preventing and treating many infectious diseases, homicide and suicide rise in the ranks of causes of death. And the risk of homicide and suicide rose to epidemic levels in the 1980s, among young adults, in particular young men, and young African-American men in particular. Further, as child maltreatment and intimate partner violence became recognized social problems in the 60s and 70s, we realized the need to move beyond reliance on criminal justice to solve just these problems. Public health professionals have hoped that their early success in behavior modification with heart disease and cancer and stroke might be replicated in the challenges underlying interpersonal violence and suicidal behavior. As a result, by the 1990s, the public health approach to violence shifted from describing the problem to understanding what worked in preventing it. Numerous violence prevention programs were developed and undertaken in schools and communities across the United States, and those early successes paved the way for the public health approach to other violence problems, such as intimate partner violence, sexual violence, and child maltreatment. Regardless, we know that currently medical and productivity-related costs of violence in the United States exceed $70 billion each year, making violence prevention the kind of an example of the importance of bringing together everyone at the table from multiple disciplines, multiple campuses, to really look at a complicated and urgent social issue. In my own research with colleagues Dr. Amy Lewin and Dr. Ali Hurtado in the School of Public Health, we addressed the consequences of exposure to violence through trauma-informed interventions with migrant Salvadoran immigrant youth, many of whom are undocumented with a community partner in Montgomery County. And in my longstanding research with colleagues like Dr. Craig Fryer from the School of Public Health and Dr. Joe Richardson, one of our panelists today, we have explored mental health, issues such as stress and anxiety and trauma due to exposure to violence, and how it shapes family involvement for low-income, non-residential, and incarcerated fathers and young men. So there are lots of different ways that violence and health have kind of grown and expanded our reach and understanding. And today we have we're going to hear from panelists who bring some of that insight from various ranges of context for violence and health. Let me introduce each of them now. Dr. Joe Richardson is an associate professor in the Department of African American Studies here at the University of Maryland, College Park. Dr. Mona Middle is an assistant professor in the Department of Family Science in the School of Public Health here at College Park. And finally, Dr. Min Shea is an associate professor and graduate director in the Department of Criminology here on campus. They'll each take a few minutes to explore their own research, touch on important findings to better understand violence and health, as well as real-world applications that contribute to our ability to prevent violence in all of its forms. And finally, we'll hear from Susan Esserman, founder and director of the University of Maryland Safe Center for Human Trafficking Survivors, in its new home here at the School of Public Health on campus.
Good afternoon. So I'd first like to thank the School of Public Health for inviting me, and also for Kevin and Susan for moderating this, this panel, and particularly for the School of Public Health for inviting me at this time, because I could be teaching, but instead I'm here. Thank you. So I'd like to talk a little bit about the work that I've been doing on gun violence in the state of Maryland, particularly in Prince George's County and Baltimore, Maryland. What was not mentioned, I also have a secondary appointment in the Department of Epidemiology and Public Health in the Division of Preventive Medicine at the School of Medicine and at the University of Maryland School of Medicine in Baltimore. So I am one of the founders and program and research director for the Capita Region Violence Intervention Program, which is a hospital-based violence intervention program out of the trauma unit at the University of Maryland Prince George's Hospital Center. And how I arrived at doing this work with primarily young black men from Washington, D.C., as well as Prince George's County, is my work focused, when I started doing this work on gun violence, on two busiest trauma units in Maryland. One, the University of Maryland Shock Trauma in Baltimore, and the other in the trauma unit at Prince George's Hospital. My mentor, who's a trauma surgeon and was the chief medical officer of University of Maryland Prince George's Hospital Center, as well as the director of the violence intervention program at Shock Trauma, Dr. Cornell Cooper, kind of mentored me through this process of learning how to develop a hospital violence intervention program in order to address the needs of young men who have been violently injured. And so my first study was actually at Prince George's Hospital Center, where I recruited at bedside with my postdoctoral fellow, Christopher St. Ville, 25 young black men who had been victims of violent injury, either gunshot wound, stab, or assault, and following them over the course of 2 years to see how they responded to being a victim of violent injury. At that time at Prince George's Hospital, our trauma recidivism rate was 32%, which meant that 1 out of every 3 young men that we approached at bedside had been hospitalized 2 or more times for a violent injury. In Baltimore, at the other trauma unit where I conducted my research, trauma recidivism rate was 58%. Well over 1 out of 2 people had been hospitalized 2 or more times for a gunshot wound. And so that study, those 2 studies, led to additional studies that I was funded through the Patient-Centered Outcomes Research through the Patients Program at the School of Pharmacy, led by Daniel Mullins, as well as Robert Wood Johnson funded study which focused on the Affordable Care Act, particularly navigators and how they enrolled young black men into health insurance that were coming into our trauma unit who were uninsured. And that study emanated from my longitudinal study with the 25 young black men, because what I found is that 90% of the young men in my study were uninsured at the time that they were injured. And so this work is really important primarily because our focus is to reduce the level of trauma recidivism among the populations that come into the hospital, and particularly in my program. And so over the course between 2013 and 2017, this research translated into the Capita Region Violence Intervention Program, and we launched in August 2017. Since that period, we have served over 100 male survivors of violent injury. At least 40% of them are for gunshot wounds. The remainder are for stab and blunt trauma. And we've only had 1 person return to our trauma unit since that period. So it's less than a 1% trauma recidivism rate. And again, to just remind you, our trauma recidivism rate was 32%. So those programs our programs work. We've also managed to make sure that every single person that has come into our program at the very least is insured. And so what we try to do in order to achieve that 1% trauma recidivism rate is provide a wide array of services, beginning with trauma-informed care. We have a clinical counselor as well as a violence intervention specialist, and our violence intervention specialist does all of the kind of non-clinical work His name is Che Bullock, and he actually was a victim of violent injury who I met through my first study at Prince George's Trauma. And he was stabbed multiple times and medevaced to our hospital. And I chose him primarily to serve as the violence intervention specialist because we needed someone in a non-clinical capacity who could go into the rooms and his story could resonate with those patients who were injured. And that's primarily the way that we were able to get so many young men to engage in the services as well as to stay involved in the program. We also have a clinical counselor who provides trauma-informed care using a model called MTREM, MEMS Trauma Recovery Empowerment Model, and a case manager. And so once we bring someone in, that's when the work starts. Once we recruit them into the program, they go through group counseling as well as individual counseling, peer mentoring, and case management. And so that has been our model, and we've been pretty successful at providing those services for the populations that we work with. The other issue that I think is really challenging for our population is looking at the intersection of the criminal justice system and the healthcare system. And what we find is that with the trauma recidivism rate is directly correlated to having a criminal record. And why is that? Well, 70% of the young men that come into our trauma unit have some history of criminal justice involvement. But the fact that they have a felony, and most have been disenfranchised from the stigma of a felony, often prevents them from going back into the legal labor market system, which pushes them, many of them, back into the underground economy, thus bringing them back to the trauma unit again. So we cannot talk about these issues in a vacuum without discussing both the intersection of the criminal justice system as well as the healthcare system and how they impact the lives of the young men that we work with. But I would ultimately say that the work that we're doing is very important, and clearly the need for gun violence research is needed. We've been able to operate, or I've been able to conduct my research on a very tight shoestring budget. The grants have been very small. Fortunately, I've recently had the support of the School of Medicine, particularly the Department of Epidemiology, to do a study there, which has been very well funded on gun violence research there. But there is a need, clearly, for this research to be supported by the federal government as well as private foundations, and we need more advocacy on the ground and by our legislators to support the work that we do because it's proven to work. Thank you.
Good afternoon, everyone. I'd like to thank Kevin and Susan for organizing this panel and for inviting us. We are covering different spectrums of violence, so I'll talk about my work, which is really focused much more on exposure to violence related to intimate partner abuse. So I'm a family therapist and a public health scientist by training, and my work is focused on improving mental and sexual health consequences of experiences of violence amongst women. This work really started for me when I was growing up in India and I was in my master's program. I was volunteering as part of my master's training at a special unit for women and children that worked with the police in a city called Mumbai. And I worked with the police whenever there was a call for any sort of victimization that women were experiencing. I would go as someone who was training to be a social worker into women's homes to help them either leave the home or to help them get connected with resources. So I really witnessed firsthand how partners, families, communities, gender roles, and other determinants of health really shaped the physical and emotional well-being of the women that I was working with. And witnessing the fear, intense emotional distress, and social stigma that these women were experiencing really dramatically changed my life, because it was easy to come in and say, why don't you leave? Why do you have to put yourself through this? But the reality is much more complex than that. And that really set me on this career path of wanting to develop and implement interventions that could both treat but also prevent these negative health consequences and life consequences of intimate partner violence. With that in mind, I came to the United States about 21 years ago to really develop more of an expertise in this area, and have continued to evolve with a specific niche, which I'll talk about more. But before I jump in and talk about my work, I really want to highlight how significant a public health problem exposure to violence amongst women is. WHO's, the latest statistics, 2013, talk about 1 in 3 women worldwide, 30% of women worldwide, experience physical or sexual violence by a partner in their lifetime. And 7% of the women worldwide experience sexual violence by non-partners in their lifetime. So primary partners of perpetrators of physical and sexual violence are really our own partners, which is really important to understand that this is not happening from really outside as much as it's happening from within our homes. In the US, the magnitude of IPV is pretty similar. 1 in 3 women experience physical violence, rape, or assault by an intimate partner. 1 in 4 experience severe physical violence by an intimate partner, and 1 in 10 have been raped by an intimate partner in their lifetime. So these are pretty dramatic figures, and the reality of lived experiences of women who are going through these is very serious. And while women experience a lot of different types of violence, I'm sure you've heard of, a lot of these different terms: child abuse, sexual violence, female genital cutting, human trafficking, femicide. Intimate partner violence continues to be the majority of the experiences that encompass trauma among women. So IPV is a very broad umbrella, right? And I'm sure most of you know about what are the different categories of violence, but I'll touch upon some of them just to give an overview that it's not just about physical abuse, which is where we tend to really punctuate, because in some ways it's easy to see and document, but violence is much bigger than that. There's sexual violence, which can be divided into kind of 3 categories. One is use of physical force against a woman to really force her to engage in a sexual act. Whether it's completed or not is not the point. The second is attempted or completed sexual act involving a woman who, because of her illness or disability or because of influence of alcohol or drugs, cannot give consent. And the last one is abusive sexual contact. Another umbrella would be threats of physical or sexual abuse, where nothing is really done per se, but there are lots of threats of hurt, violence, injury, or even death. So really keeping a woman under panic. Then there is psychological violence or emotional violence, which increasingly research is showing can have even more dramatic health impacts compared to physical violence. And then there is stalking, which increasingly we've become more and more aware of. Research from industrialized nations is really pointing to 2 groupings of violence. One is the more moderate type of violence, which is called, in the world of family therapists, the common couple violence, which may be more bidirectional. Oftentimes you might hear about this quite a bit, where the woman is hitting, but the man is hitting too, so it's bidirectional, the consequences are different than the one where there is more fear and more power and control. Violence has significant and serious health issues that impact women, and my work really focuses on sexual and reproductive health. A recent Guttmacher report highlighted that about 103 million women in the United States have become pregnant against their will because their partner refused to wear a condom. 2.1 million became pregnant as a result of rape by an intimate partner, and 1.8 million contracted a sexually transmitted infection as a result of experience of intimate partner violence. And my work focused primarily on HIV, and now we know about 12 to 22% of the HIV infection rates among women can be attributed to their experiences of intimate partner violence. Now a lot of us are public health scientists. For intimate partner violence to have 12 to 22% of the risk that causes HIV is really, really high. So in terms of my work, I do look at primary and secondary data to see what are some of the risk and protective factors for IPV and adverse health outcomes. I've also looked at how and why. What are the links between intimate partner violence and adverse health outcomes, particularly in relation to sexually transmitted infections and HIV. And then I have a portfolio where I develop interventions and I evaluate these interventions which are aimed at reducing both risk for intimate partner violence and improving sexual health of women. Currently, I have a grant which is focused on doing a couples-based intervention because working with the woman is important. However, expanding it and looking at factors at the relationship level is extremely important as well. And currently, we are developing and testing a couples-based intervention which addresses the syndemic health issues of intimate partner violence, substance use, and HIV risk behavior together. Thank you.
All right, good afternoon. Thank you for being here. I'm honored to be on this panel for the discussion of the important issues on violence and public health. And I'm an associate professor in criminology and criminal justice here at the Maryland. And my approach to the study of violence has been influenced by my education. I have a bachelor and master's degree in information management. I got them from Peking University in China. And then I minored in law. So when I was in graduate school, I briefly worked at a law firm after I passed the bar exam before I decided to pursue a research career in criminology. So I came to the US and got my doctoral degree in criminal justice from the University in Albany in the SUNY system. And then my first faculty position was at Arizona State University, where I got my tenure before I moved to Maryland in 2014. So because of my education in information management, I'm particularly interested in the national data systems on violence. And so my specialty is handling the National Crime Victimization Survey, which is actually the largest victimization survey in the United States. The survey has existed since the 1970s. Currently, the survey interviews more than 200,000 people each year with a response rate of over 80%. So the response rate is very high because it's conducted by the US Census Bureau, where I actually work. I feel like I have two jobs, one in Maryland, one at the Census Bureau. I currently use the data to study several types of violence that are very interesting to me, including violence against women and violence against by intimate partners, family members versus by strangers. And then violence experienced by racial ethnic minorities, including Latinos and Blacks. And finally, violence experienced by residents in immigrant neighborhoods. And in order to understand why it's so important to look at this line of research, the best way for me is actually to try to compare the victimization survey data to other data sources on violence in the US. So most commonly, people use crime statistics that you can get from police departments that are compiled by the FBI. Or you have data on homicide from the police departments or from health departments like vital statistics. And also you have different agency-based violence statistics like you can get from the medical centers or hospitals or trauma centers or victim shelters, for example. And as you can see, a large proportion, a lot of times more than 50% of those violent victims would not be captured by those data sources because victims do not call the police or they do not get help from those medical or professional agencies. And therefore, in my research, I've spent a lot of time and energy to find out who are these victims that are hidden from those systems, and in what regions or communities do these people live. And then, more importantly to me, is what kind of violence prevention strategies could work better if these people do not call the police, or when they call the police, what would be the best approach to handle those incidents. And for example, in my most recent research of looking at Latino and immigrant communities, I have found that a place that's particularly vulnerable to violence that deserves special attention are those places that we call, or actually researchers call them, the new immigrant destinations. So those places have seen, in most recent years, like in the last 10 to 20 years, a huge increase in their immigrant population, but they do not have the kind of resources or support to help the immigrants, largely because they didn't have a traditionally large immigrant population base. And therefore, in my research, I found that the violence rates in those areas are very high against our Latinos, who are between the age of 18 and 34. And then also, the rate at which these violence being reported to the police are exceptionally low. This is very interesting because if you compare similar kind of people who live in the traditional immigrant places, the picture is completely different. So based on our analysis of the data, you can sort of see the public health outcomes for those residents in those areas are really bad. And then because of a lot of those incidents are left untreated, so those incidents tend to have very high negative consequences for residents in those areas. As a result, currently, I'm working with a group of researchers and students here at the University of Maryland and also at the Penn State University by using funding from the National Science Foundation to examine how different states and counties make policies regarding immigration enforcement, employment, and housing to see how we can actually make better policies to deal with these unreported crimes. And this work is interdisciplinary, and I'll be really happy to address any of the questions if you are interested in this research. Thank you.
Good afternoon. I was interested to hear Min's background in law. Well, I'm a lawyer by training, but it's that experience representing human trafficking survivors on a pro bono basis that led me to approach the University of Maryland to establish the University of Maryland Safe Center for Human Trafficking Survivors. And that's because it became very clear to me that a legal approach alone would never enable traumatized human trafficking survivors heal and overcome the trauma of their trafficking. So at the Safe Center, we provide comprehensive services for both sex and labor trafficking survivors. Our mission to prevent trafficking and to help survivors holistically heal is through policy advocacy and research in addition to providing services. In the nearly 3 years that we have been in operation, we have established ourselves as strong service providers and policy advocates and as an engaged community partner. Now, informed by our direct frontline experience serving human trafficking survivors, we are now able and ready to turn to research to address prevention and interventions at an earlier stage. We are especially happy to join the School of Public Health and to have the opportunity to approach human trafficking through a public health lens. Our center's human rights perspective and mission to help survivors holistically heal and rebuild their lives are aligned with the public health approach toward prevention and wellness. Human trafficking is an inherently violent phenomenon. It is the use of force, fraud, or coercion to compel victims to provide commercial sex or labor against their will. Human trafficking is a worldwide problem, and it's fueled by globalization and the internet. The International Labor Organization estimates that 25 million people around the world are trapped in trafficking. Trafficking takes place on this massive scale because it is an incredibly profitable criminal enterprise. But trafficking is also a national and local issue, and there is a disturbingly high incidence of trafficking in our own region. Our location on the I-95 corridor and our many transit hubs make this area a hotspot for traffickers. Human trafficking is not only inherently violent in itself, but violence is one of the root causes of trafficking. People who have been sexually abused as children are more vulnerable to trafficking. Violence in the home that causes a youth to run away puts the youth at much greater risk of trafficking. Immigrants fleeing gang violence, conflict, and domestic abusers who act with impunity are at greater risk of being trafficked. Trafficking relies on the power imbalance between the trafficker and the victim. Traffickers prey on the vulnerable, the impoverished, and the oppressed, homeless youth, abused children, migrants and refugees, children involved with the child welfare and juvenile justice systems, and LGBTQ youth and adults. Gender inequity and norms are also an important driver of trafficking, and there is obviously a tie between that and the power imbalance. Disproportionately, victims of human trafficking, including our own clients at the Safe Center, are immigrant women and girls of color. Of the 120 survivors we have served at the Safe Center, over 90% are female. More than 95% of those who are American-born are African-American women and girls. And our foreign-born clients are largely from Central America and Mexico in the case of sex trafficking, and the Philippines and African countries in the case of labor trafficking. As we think through public health interventions, it's important to consider, obviously, the relationship between trafficking and other gender-based violence, and also the intergenerational cycle of violence that is so often present. That advances in technology and finance have pushed human trafficking online, making it more challenging to detect and to prevent. The convergence of the opioid crisis with sex trafficking, as traffickers use opioids to entrap and maintain control over their victims, and the importance of developing interventions targeted to the unique different forms of sex and labor trafficking. There is a serious paucity of quantitative and qualitative data in this area. So at the Safe Center, we're undertaking research using respondent-driven sampling, an approach proven to be successful in estimating hidden populations, to measure the extent of human trafficking in this region. We're also advocating for early services intervention by actively shaping legislation in Annapolis that would lead to identification of trafficking at an early stage and trauma-informed services for child-exploited youth, with the objective of intervening before they become caught up in the criminal justice system. One of the Safe Center's major goals going forward is to broadly engage the health delivery system in our area to focus on prevention, identification, and specialized treatment of survivors. Interestingly, research shows that a substantial majority of human trafficking survivors engage with the medical system while and after they have been trafficked, but they largely go undetected. So we see that opportunities for intervention are missed here, and this, in our view, is a very serious gap. As we go forward, we plan to draw on pioneering research in this area by HEAL Trafficking and others, and the work of forensic nurses in emergency departments and hospitals in our area. And I just want to say that Dr. Askew is here, a great partner for us going forward, a pioneer in this area, and the vice president of the HEAL Trafficking Board. And most importantly, he's now come to Prince George's County to be the Deputy Chief Administrative Officer for Health and Human Services and Education for Prince George's County. So he is going to be an important partner for us. So finally, this initiative that we are undertaking will clearly require studying intervention models that have worked for other public health issues. And in this regard, we are especially interested in the work of Dr. Joe Richardson's hospital-based violence intervention programs. Thank you. So I would like to open up the conversation by asking our panelists a question that I'm struggling with as someone quite new to the public health field. And that is that it's a challenge to identify how far upstream to intervene to prevent violence in our communities. It's important to choose our interventions entry carefully so that we have the chance to intervene and to affect macro factors, but by doing it, we do it without diluting our more specific work and tracking micro factors. So I'd like to ask our panelists, what's your perspective on this question?
So that's a really great question, because I think that's the challenge we often face with working with young men who have already been injured, and we're seeing them so far downstream in the trauma unit. We recently, my colleague and I, knowing that, recently started a program which we're working in Eastern High School and in the district, working with young people who are at risk for truancy and violence, providing trauma-informed care and teaching kids, primarily between the ages of 14 and 16 years old, about trauma, how they should deal with trauma, and then being able to go back into their own networks and families to train their peers as well as their family members about trauma and how to deal with that. And I think the trauma-informed care approach needs to start much earlier. Not just when someone's in the trauma unit and at bedside, but what we're finding is even among the young men that we work with in our hospital violence intervention program, that there are a host of issues of complex trauma that are not just associated with PTSD, which we typically tie post-traumatic stress disorders to the violent event, but trauma that's occurred over the course of a lifetime. And we don't typically think about that when we're working with male survivors of trauma, that their trauma is often started with adverse childhood experiences and events. And so we need to have a model that starts very early on addressing that kind of trauma. So I would definitely say that we need the replication of programs that provide a trauma-informed care model within the school system.
That's a question that I think most of us, irrespective of what we do, often struggle with is, upstream versus downstream. So I've been on that journey as well in terms of deciding as an individual researcher where do I punctuate my work, right? Where do I start? Because I'm not part of a big enterprise where we have multiple arms that can focus on both prevention and intervention. And as a family therapist, for me, I was trained to intervene. So my focus, the focus of my work is on secondary and tertiary prevention, but I think primary prevention is critical. And I don't think one at the cost of the other, but we have to figure out how to do both and. In the area of intimate partner violence, I would say to do primary prevention, like in any other field, requires a significant understanding of risk factors that influence people either becoming victims or perpetrators or both and. And I think even though the recognition that violence, intimate partner violence is a public health issue was about 4 decades ago now, we've made quite a few strides in trying to develop and test primary preventions. I think we still haven't come to a point where it's deployed at mass scale. But some of the main things that countries are focusing on are strengthening laws and policies, early childhood and family-based approaches. So even in my work, even though I work on secondary prevention, the idea is if I can improve relationship at the couple level, it indirectly improves parenting and reduces intergenerational transmission of violence within families. Oftentimes, school-based activities, which you just talked about, are really critical. Interventions to reduce substance use, and that include alcohol and drugs. Creating more public information, changing social norms, I think are some of the key things that come to mind when thinking about primary interventions.
Is this working? Okay. For criminologists, we have a long line of research talking about like developmental approaches to violence, where people will talk about early intervention, which I think there are sufficient evidence to show that intervention at an earlier age would be helpful. But in terms of my own research, because I tend to compare the system of criminal justice system versus another system like services provided by non-police agencies. And it's very important to look at this issue because in the 80s, people talked about how it's important for police to be involved in dealing with intimate partner violence, and we started to see law changes in terms of mandatory arrest laws and so on. And then the literature now has been showing evidence that those approaches tend not to be as effective as originally thought. And actually, when intimate partner violence happened, the type of services these victims might receive see a much visible impact in terms of whether or not they will be experiencing similar types of violence. And therefore, in my research, I think it's important to consider like how you can change circumstances closer to the crime incidents and the family as well. But of course, I don't think we should give up the idea about early intervention because it's important.
Well, thank you for those answers. They're all very, very interesting. And Min, in particular, your last comment about closer to the issue. Because Mona, I was recently in India and meeting with anti-trafficking activists, and I was overwhelmed by the broader societal factors affecting women that, clearly are the most important driver, and that as I thought about and been learning about public health, it seems that that's a very hard kind of intervention to deal with. That doesn't mean that we don't try and participate and contribute our experience, but those are deep, deep issues. So at this point, we'd like to open it up to the audience for questions.
So there's a microphone. You can come on up and we'll sit down, and we have about 15 minutes left for your questions.
My name is Jim Curry. I run a nonprofit organization that represents the officers in the U.S. Public Health Service, so many of my members are here today. I get the impression, and maybe it's just because I'm a layman on this sort of thing, that our legal system doesn't take human trafficking very seriously. And I base that on what I have seen recently down in with news reports on what happened in South Florida at the spa down there, where a very wealthy and very famous man who owns a professional football team was going in and taking advantage of the services being offered by women who are apparently being illegally trafficked and forced into these things. And from everything I have read, in the press at least, he's probably going to get off. And yet, if there were no demand for that sort of thing, there wouldn't be the supply of it. And it seems to me like, as a society and as a legal system, we're sending the wrong message there. And I'm wondering what you might think about that.
Well, I do agree with you that there's certainly inequity in sentencing based on connections and wealth. That's a broader problem, much broader than human trafficking. What we have seen is that there is increasing understanding of the perniciousness of sex trafficking. And when we first discuss human trafficking, people do not believe it happens in this country. And they especially do not believe it happens in our region. There was no time for it, but I should just tell you that in terms of per capita incidence of human trafficking by city, in 2016, Washington, D.C. ranked first and Baltimore 14th. And Maryland was the 13th, the state with the 13th most reports of human trafficking. That was a very disturbing incident. Also, the fact that it was cross-state. And, you know, we are at the Safe Center going to try to link in because of the broader impact of that. But it was also important for people to read about the details and see that it's real, because I will tell you, when we have worked with certain police partners here, they do not believe that sex trafficking occurs in these massage parlors. They say it's all voluntary. Now that case hardly looked voluntary given that setup. So I think the exposure and the fact that the police had been investigating for some time and took it very, very seriously. I will say one other thing. There is an absolute lack of seriousness about the issue of labor trafficking. It sounds less pernicious than sex trafficking. It is another form of slavery. And it happens a lot in this area. About a little less than half of our own cases are labor trafficking. And I'm very happy to say that the Safe Center was in the middle of advocating for legislation, testifying, writing op-eds to advance having a labor trafficking specific legislation in the state of Maryland. And I believe by the end of the session, it will have passed, actually unanimously in one house and nearly in the other. But thank you very much for your question.
Hi, Boris Lushniak, University of Maryland School of Public Health, College Park, just a public health guy. Question to you. First of all, welcome to the Safe Center. We are so happy to have the Safe Center part of the School of Public Health and the family here, and we'll continue to work with the School of Public Policy here at the University of Maryland, College Park, with the School of Social Work up in Baltimore, and other partnerships with the schools and colleges to achieve a goal. This question really is to all the panelists. And in essence is, you know, I look at the theme for this meeting today, and it's health and well-being for all. It all fits. But the subtitle is just as important. It talks about working together across sectors. And the questions to each of you is, from your perspectives, who is a key partner across these sectors? This was part of the issue or part of the theme of the Surgeon General's talk this morning, that we expand our horizons. And really, to keep this brief, name a key partner that currently is perhaps not considered a public health partner, but works with you. And then let's fantasize a little bit. Let's look aspirational. Who would you like at the table that's not at the table right now that would achieve a goal of prevention, health, and wellness?
I have a lot to say about that. So I definitely believe the work on gun violence is interdisciplinary. And so for me, and my work represents it. For example, I'm in the Department of African American Studies and also in anthropology as well, and in the School of Medicine. So I think you need everyone at the table: School of Medicine, School of Public Health, definitely the School of Social Work without question. We can't do the work that we do in the hospitals without really quality social workers, clinical counselors, and then you need the help of the community. And I think what we're missing in this discussion, and what we often miss in academic discussions, is where's the community voice in all of this, right? How do we get parents who have children who have been victimized into this conversation? One of the things that we focus on in our program is bringing in caregivers. And I've interviewed numerous caregivers about the impact of vicarious and secondary trauma. What does it feel like to have a son who's been shot on 3 separate occasions and he has to leave every day out of his home and go into the street? What does that feel like for a parent? What does it feel like to take care of someone that's been paralyzed, right? And so the ideal world would be to have scholars, practitioners, and the community all at one table. And I have to give a shout out to the Center for Victims Research, because I recently was funded to conduct a study called Life After the Gunshot, where I interviewed 10 young men who had been victims of gunshot wounds and filmed them. But the basis of the research was bringing together researchers and practitioners, because we need to have both at the table. So we need the clinicians, as well as having the scholars and those who have been impacted by violence, all sitting around at one table and engaging in dialogue and coming up with some really innovative solutions. And that's the only way that we're really going to push the innovation, is to think outside of the box by including more people in that conversation.
I think it's very important for us to have a picture of the current funding sources and also data sources on all the victim service agencies. Like, so if I actually have the ability to decide who's going to be at this panel, like, I would like to, for data, currently the Bureau of Justice Statistics are working with RAND and other organizations to compile the census of all the victim service agencies in the country. And they have not been able to release the data because it's still in progress, but that would be very important to have. And then also the way we distribute funds to all the victim service agencies would have a huge impact in terms of what types of victims or types of crimes that we can provide service to. And so those, I think it's important to have people at that level which can make a lot of important decisions for these types of research.
I would echo with what Joe just mentioned in terms of the 2 main people that I feel like I constantly struggle with as I do work in my area is establishing community partnerships. And I always feel like I'm running against time to establish these partnerships that are long-term, that it's not one project at a time, but really a vision that we see together that we work on. And the second is really having the people that these community partners are serving at the table in a sustained long-term partnership. Those are the 2 main things.
Currently, we are really quite engaged with community partners. I will say, and this may sound inconsistent with what I said before, but law enforcement is absolutely a key partner. And sometimes people who are upset about the involvement of the criminal justice system will say, how can you work with them? Well, we are not going to be able to save survivors by ourselves. Number 2, they often are the point of recovery, and we need to make sure that what they do is trauma-informed and victim-centered. So they're just a critically important partner. In fact, we have a grant from the Department of Justice that facilitates that in recognition of the importance of it. I'll just say another that is absolutely a thrilling partner. We've just been very pleased with the impact that it's had. We are working with the AME church leaders in Prince George's County. And I was especially interested in how they participated and got the word out about labor trafficking. And there, we see them as an important eyes and ears in the community, a source of information about who might be affected. So this is something that has really been quite meaningful. I'll say looking forward that, as I suggested in my comments, we certainly would love to have the full range of medical partners at the table. But I'll also say something else. This is long-term. I want local businesses at the table. Because ultimately, now looking from a broad public health perspective, if our survivors do not have good work, then they will never recover from their trafficking. And I think that's going to really require greater understanding of the business community.
I'll just add one more point. In some of the work we're doing in Montgomery County, working with a community partner who's been in the field for 20 years, working with youth and after-school programs, their Identity Incorporated, we follow their lead, and very much they've been working within the school system for 20 years, trying to advocate for Latino students, in particular immigrant Latino students, and recognizing the challenges they face. That relationship has taken us 2 or 3 years to even get off the ground. So part of this is, these are not quick fixes. These are long-term relationships. Bringing people to the table is not a one-time meeting. It's many years of investment in this. And as Identity has worked through the school system, they've also worked with criminal justice. They've created their own health centers within high schools because of the lack of support or lack of resources in that way. And it brings me back to a comment that John Rich, who's a physician in Philadelphia, made, and he works a lot with the young men that Joe works with who've been injured through gun violence. And he says we need to move past just the reliance on the medical model and just a reliance on criminal justice to recognize from a public health perspective that we have young people, we have families living in toxic environments. And the question we need to ask is, who hurt you, as opposed to what's wrong with you and how can we fix it? And we begin to look at the environments, then we need to look at the systems that folks are not willing to engage with, they don't trust, they're flying below the radar screen to protect themselves. And these are the folks who want to ask at the table. Those are really difficult questions. They take a long time to address. Other questions?
Hi, my name is Michaela Walker. I'm a first-year MPH and Health Equity student at the University of Maryland School of Public Health. And I guess I have 2 specific questions. The first one is sort of stemming from the past 2 questions that we just discussed. You all, as you mentioned how when it comes to human trafficking, people just don't believe it's still happening. And then when we look at gun violence, we hear about shootings all the time, and we see all these shootings on TV, yet people are numb to it, or we haven't really been able to move past towards legislation or towards other programs or initiatives that can sort of break this pattern that we're seeing in our country. And I guess mentioning all those stakeholders we talked about in the second question, what can we do to get people to care, to get people to sit at the table, so that we have all these issues, like how can we improve what we have right now? And then my second question, you all work with victims of horrible violent issues, and so how do you all specifically care for yourselves when it comes to working with these victims?
I'll take the second one in terms of self-care. How do you do that? Not well. Or attempt to do that constantly, right? But I'm not sure I always succeed. But I think it's really, really important to have a good balance. And I don't have the answer. You know, I'm always told, don't take your work home, but I'm constantly taking it home, so I'm not the right role model to be able to talk about this. So it's a work in progress, honestly. I feel like I have phenomenal colleagues at work who are really my friends. And we do such intense work that it's very nice to walk into a colleague's office and just say, this is what I'm feeling like. Do you have 5 minutes? Can we take a quick walk? And it's okay if they don't have time, but being able to have that supportive network, I think, of people who understand what it requires out of us on a day-to-day basis is critical. Having a very strong team of people that we rely on as we do the work together is also very, very crucial. So that begins with great students, great staff members, having a great community advisory board. So we kind of doing this work together and not alone, I would say, is the main thing that helps me when I'm feeling extremely down. And always going back and remembering why I'm doing the work is so important, because there are times when I feel like, why am I doing this to myself? And then I remind myself about where I get that passion from, and that kind of lights the fire again. So, and I forgot your first question, I'm so sorry. But I'll let somebody else answer that.
So for the first question, I would definitely say that what we don't really, at least each hospital that's involved in a hospital has a hospital violence intervention program. And let me add, there are only 35 in the world. So you have tons of trauma units that are out there, but there are only 35 programs in the world that have a hospital violence intervention program. And so I don't think many people know that. So just getting the word out about what we do is really important, and how much we save. And that's really the challenging part, is attaching a cost to it. I was giving a talk maybe a month ago, and I was talking about how things are really out of scale with funding. And I'll give you a good example. So 30% of our population that we treat for gunshot wounds and violent assault comes from DC. So we get funding from the DC Office for Victim Services and Justice Grants. That covers roughly about $150,000 for our staff. That includes a clinical counselor, a violence intervention specialist, and a case manager. But if you really put that in context, we treat on average 740 victims of violent injury a year. We have the capacity to serve 60 in our program. But a young man could come in with multiple gunshot wounds and stay in the hospital for 3 or 4 days, and his bill could be roughly $300,000. In one person, we've doubled our budget. So it's just totally out of scale, the amount of money that we're given, a drop in the bucket to what it really costs to solve the problem. And I mean that kind of across the board, whether it's a criminal justice issue, which is $80 billion, or violent injury. It's out of scale, the amount of money that we're chasing. There's $1 million grant out there, and I'm on the advisory board for the Governor's Office for Crime Control and Prevention. And we were on a call yesterday, and there are 10 organizations chasing $1 million. It's $100,000 an organization. When I just mentioned to you, you could have someone that's been paralyzed, they may leave with a $1 million bill, right? So I don't think people really understand the scale of the issues that we're dealing with. I would like to say that another funder who, in an idealistic world, who should be around the table, and this is something I don't think many organizations think about, but has been very instrumental for our organization, is Uber Health. We Uber our guys to the services and back to their homes. It's critically important. We spend at least $1,000 a month, and that's light, to get guys to the services, because otherwise they would not come. So giving someone a Metro card or a token and expecting them to show up to services once a week, sometimes twice a week, it's illogical. And so every organization needs to think about how they can build Uber and Lyft into their accounts, because it's totally increased the uptick of services and the access to services that our young men are involved in our program are taking advantage of.
We're going to have to wrap up. One last point I think that's important in the face of the last question, and to end on this note, is in the face of going numb and wanting to continue to care, these are crises we're dealing with. I think as researchers, the best that we tune ourselves to the resilience of survivors and celebrate and understand and support the strengths that they bring as well in getting through what they're getting through. Bringing a strength-based approach as opposed to just a deficit-based approach to the advocacy we do is very important, and I think across the board we see our community partners doing that, and I think you see a lot of us doing research. We'd like to thank you very much for coming to the panel today, and we're going to move on to the next segment of presentations. But thank you very much.
Let's hear it again for this incredible panel. This has been an incredible day. Each of the panels that we've had, and especially this one, could be several weeks long in terms of getting to the depth of the issues. And thank you so much for the suggestion of the Uber Lyft, because that has come up in our study on rural health as well, is trying to find out how to deal with safe and energized transportation. So we are now going to turn to a part of our program that always brings joy, we hope. It is the announcement of the awards for the posters, the student-presented posters, and then also the awards for the photograph competition. And we had wonderful co-leaders for the judging, Dr. Marion Moser-Jones and Dr. Nancy Ellish, who are going to come and present the winners. And we will then be able to take a photograph with Dr. Magaziner and Dean Lushniak up here with each of the winners, and then we'll have our closing remarks. So.
Hi, everyone. Thank you so much for sticking around for this. And also I'm going to thank Dr. Nancy Ellish, my co-director of this poster session, without whom the session would not have been pulled off. And also thank you to Dushanka, whose leadership helped us to get to this point. And to our judges, our selfless judges, especially those who volunteered at the last minute for extra sessions or just showed up and said, do you need judging help? We very much appreciate all of you. I think all of the students who came and presented posters should be commended for your efforts. And overall, I'd heard, yes, that the judges were very impressed with the quality of the posters. So we're going to start, without further ado, with the undergraduates. And everyone who gets an honorable mention gets a $50 gift card for Barnes & Noble or bn.com, and the winners get a $100 gift card. So the first honorable mention for undergraduates goes to Delia West. Come on up. You're here. Come on up. Woohoo! Yay. And the second goes to Adewale Awoyimi. Yes. All right. Woohoo! Come on up, come on up, come on up. Yes. All right. Adewale, yes. And Delia. Oh, you are? Okay. I was like, yeah, I thought you were a professor. But you know, in today's school. And first place, drum roll please, goes to Eileen Yee. First place. Yay! Excellent. Does someone, okay. Yes. And so now we'll turn it over to Nancy for the master's students. Oh yeah, photographs. Okay. Yes.
I like to read.
You want to make sure you get your award, right?
Thank you. Nancy, why don't you get it in the photograph? Come on.
Okay. All right. And then we're going to go on to the masters.
You need to be in the photograph.
Okay, for the master's students, honorable mention goes to Erica Van Zyke. And the second honorable mention goes to Ajuni Chaudhary. I don't know if I pronounced your last name right. Congratulations. And then the first place goes to Emily Jenkins. PhD. So last and certainly not least, we have the doctoral students. And the first honorable mention goes to Fiona Jardine. So come on up. The second honorable mention goes to Harry Lee. And the winner, the first place winner of our doctoral competition for the poster session is Hillary Craddock. And finally, we have, after the pictures, we have the photo contest. So is Harry Lee here? Nobody here? Is anyone here for Harry Lee? Okay. Hey, come on up, and you can accept it. Hillary, yes, congratulations. Thank you very much. All right. Yes, come on up. Do you have the good content? For Harry, yes, right here. No? Yes, right here. Okay. To his advisor, come on up. Yes. Hi. To Susan. Sorry.
Can I just accept this for him and not be in the picture?
All right. I did the first two, okay. Okay. You want me to? Yes. Okay, for the photo contest, we have a very exciting public health photo contest showing that we are multidimensional and multimedia. And the third place award goes to Nahid Ahmed. Nahid, are you here? All right. Oh, and look at this amazing photo. Okay, Nahid is not here. I can accept this award on her behalf. She's in my department. And the second place award goes to Emily Jenkins. Yay! And these are right here. Thank you. And the first place award, our winner of the photo contest, is Katarzyna Borkowski. All right, is there anyone here to accept the award on behalf of Katarzyna? Okay. Well, thank you all so much for participating, and have a great afternoon. This is Katarzyna. Oh, thank you. Stick around.
Okay.
Stick around for closing remarks.
We're just going to finish up with some closing remarks. Jay, anything to say? Come on up.
Well, you were going to say something else? Yeah. So I'll just say thank you for coming, and I think it's been a very exciting day, and I'm sure everyone wants to hit the road. So I'll let Boris take the next 15 minutes and tell you some exciting things.
Great. Well, thank you very much, especially to Drs. St. George and Dr. Kleiman for once again taking the burden upon your shoulders for running and putting together such a great day of public health here at Maryland. To all our partners out there, and in particular the people who play a role in terms of sponsoring this get-together, and that includes obviously the School of Public Health, the University of Maryland School of Medicine, the University of Maryland Strategic Partnership, which is empowering the states, which brings us together, the Commissioned Officers Foundation, and Delta Omega, the honorary Public Health Honorary Society. Those all organizations are important in terms of getting, obviously, people here together, in terms of the support. We're always looking for extra sponsors, so if you're out there, wanting to support this endeavor here, we do this every year during National Public Health Week. It's critical that we continue this. This is year number 7. What's interesting is that ultimately we start, we take a day off, right, Dushanka and Dr. St. George? And then ultimately we start 2 days from now planning for next year. To the incredible staff, there's multiple staff support here, and I always hesitate the idea of naming names, but once you come up here and name names, because you know who has been sitting in the offices with you, and it's important these people get acknowledged, and we'll save applause for the very end, but for them. But this is the key group that does all the work.
Well, Annika Sidrahara, Annika, you're in the back. Rachel Sturgis, in the back. Aaron McClure, and Andrew McCarthy, Alex, Ellie Blake, Mary Shelley, Jonathan, and all of the people that in the office. I mean, we have tons of volunteers, all the judges that played a role, and so I want to thank you all for doing such a wonderful job, and again to Nancy and to Marion for their judging. So.
Thank you so much. And like the theme started with this morning, is we're here to sort of think of the partnerships, think of the sectors that need to be here. We'd love to hear from you, the participants today, and I know we've dwindled down the size, that happens every year, but ultimately part of the feedback is which sectors aren't here that should be here during this meeting. I finished today with a new feeling of enthusiasm. You know, there's always that sense that at the end of this meeting, if you aren't lifted up, if there isn't that sense, as I mentioned earlier today, the optimism of what we can do in public health, then we've not achieved our goal. Because at the end of this day, whether it's the idea that you've learned something new, whether it's a new person, a colleague, a friend you found here today, whether it's the inspiration of walking through the poster sessions and seeing what our incredible students from all sorts of different facets are putting together, whether it's seeing the Commissioned Corps of the U.S. Public Health Service in uniform walking around, there's various facets here today that inspire us. And so I hope you leave today realizing that we still have the rest of the week to celebrate. And like, I'm a twit, and so I tweeted earlier today. I think that's the word. My wife tells me if I tweet, I'm a twit. I think that's what she told me, so I use that term lovingly. As a twit, I tweeted earlier today, and part of what I tweeted was this idea that we celebrate National Public Health Week, but once it's over, what do? We roll up our sleeves and we begin to change the world again. So anyhow, this is that stepping off point where take it slow on the way home today. Those of you who are driving, be extra careful. Deal with the traffic and all the situation. But at the end of the day, thank you. Thank you so much for being here. Thank you for being active participants. Roll up the sleeves. Let's work. Thank you.